I'd like to introduce Dr. Richard Lewis, who's graciously come up from the Los Angeles area to give us a talk. Dr. Lewis, who I've known for quite a few years now, has a strong interest in inflammatory neuropathies. He has, but in regard to his training, he trained at the University of Pennsylvania, where he did both his neurology and fellowship training. And then he moved on to Wayne State, Henry Ford Hospital, is that right?
Wayne State University.
Wayne State University, where he rose to the ranks, became full professor and associate chair at one point before taking the job at where he currently resides at Cedars-Sinai, and he's full professor there. He's published numerous papers on various topics in neuromuscular disease, especially in inflammatory neuropathies, and he's even had a disease named after him, Lewis-Sumner syndrome, of course. And he's going to talk to us today about new concepts in demyelinating neuropathies, nodal and perinodal disorders. Thanks, Rich.
Thank you, Axel. There we go. It's a pleasure being here. I have been to Seattle a few times. My son worked here for a while at Microsoft and had one of those great jobs after college working on the Xbox, and so it's been delightful to be here. Besides my interest in inflammatory neuropathy, I've been interested in demyelinating neuropathies in general, and I just had the pleasure of seeing Tom Bird after a few years, and it's one of the things we were involved in a lot. It had to do with Charcot-Marie tooth disease, and I'm going to talk about that a little bit in relationship to this disorder. So almost none of this has anything to do with my own work, and I'm basically going to talk about something that I'm interested in that I think I've started to think about in a different way, and I thought I'd try to share that with you and see if you're as interested and as excited as I am about it. So the reason I put this up here, and this again, Mike Razminski was gracious enough to give me some of these videos. This is a video of a single nerve fiber. Obviously it's a cartoonish video of a single nerve fiber's conduction. And as you can see, this little white dot is the node of Ranvier. These long lines are the internodal myelin, and you can see the action potential. This is not a computer simulation. They did this back in the early 70s. And what they did was they basically took a mouse and dissected out the nerve roots, stimulated the tail nerve, and tracked about 200 microns and tracked the currents that were being seen at each of the locations. So this is normal saltatory conduction. Let's see if I can get out of this. Here we go. Now here you'll see that this is the same kind of normal node of Ranvier, and here are two little heminodes, or two little hemicircles, which is showing perinodal demyelination, which was done by dropping a little bit of anti-galactocerebrocyte serum on these nerves. And let's see what we see here. Let's try it again. Please work. No? Let's try it this way. Well, that's disappointing. One worked and one didn't work. So what this was supposed to show is normal conduction here, a very delayed action potential here, and conduction block here. And what this was the first demonstration that just a little bit of perinodal retraction was enough to cause conduction block because of shunting of these potentials. And I wish I knew how to make this work for you, but I don't. And why one worked and one didn't work, I don't know. But we better move on. This talk is relevant in part because of this is the 100th anniversary of the publication of the Guillain-Barré article on the Guillain-Barré syndrome. and we will be celebrating that in Glasgow in the end of June. It's a wonderful meeting if you'd like to go. If any of the trainees have some work that could be presented as an abstract, they basically give you full training grants to travel grants. So you can get there, they'll pay for your, I think you just have to pair up and find a place to stay, otherwise it's all free. So it's worth doing if you have something, and it is a wonderful meeting. This is the Inflammatory Neuropathy Consortium is part of the Peripheral Nerve Society. It's worth, Tom, have you ever been there? Yeah, you've been there a few times. It's a great
Who actually
meeting.
is paying for it? Where does the money come from?
The money comes from, we actually make some money on these, what do you call it, these consortium meetings, and we keep it and we use it for grants. The Peripheral Nerve Society we use it for grants for research, and we use it for travel to get young people interested in the things we're interested in. So I have some disclosures, and they're there. So what I want to get across for the rest of this talk is that I want us to rethink a little bit about how we interpret conduction slowing and conduction block, because they've been defined as being signs of demyelination, and I would say that that's not always the case. There are immune-mediated toxic inherited disorder of the Node of Ranvier that we don't tend to think about very much, and I want to bring them to your attention. These disorders have started to make us think about the structure and function of the Node of Ranvier, and also how we interpret nerve conductions, and there are some new disorders that are now being recognized. So even after I started, but 20, 30 years ago, the idea of saltatory conduction in myelin and the axon was that the myelin was there to act as an insulator to allow for saltatory conduction. That we didn't know any of the interactions between myelin and the axon, and it was actually myelin protein 0 disorders that actually started to stimulate our thinking that the myelin and the axon actually communicate much more with each other, that they're interactive, that they need each other to survive, and has led to a body of work that has shown some structural aspects of the peripheral nerve as well as physiologic ones. So we now know of things like Neuropathy 155 and Casper and Contactin that basically connect the paranodal loop to the axonal lemma. We know of myelin proteins that are seen in the Schmidt-Lonneman incisors in the paranodal loops, like connexin 32. And we know of some structures in the Node of Ranvier that affect sodium channels. So 20th century thinking was myelin was designed to promote saltatory conduction, and conduction slowing was caused by segmental demyelination, as was conduction block. Now we're thinking about the myelin and the axon interact more, and conduction slowing and block can occur without segmental demyelination. So a little bit more about this nodal structure in the most recent, and a lot of this is taken from my old colleague Xun Li, who wrote this really wonderful review in experimental neurology in last year, and I strongly, if you have any interest in this, to understand what's going on, it's really a wonderful review. But duroregulin is a major regulator of intermyelin thickness, where periaxin determines internodal length. And those two features of myelin are crucial to conduction velocity. So you need a specific amount of myelin thickness and a certain internodal length to optimize conduction. In the Node of Ranvier, the sodium channels interact with neuropathin 186, seen here, ankyrin, and this beta IV spectrin, whatever that's supposed to be. In the paranode, we talked about some of the proteins, including myelin-associated glycoprotein, and neurofascin 155 and contactin are crucial aspects of this connection between the paranodal loop and the axonal lemma. The voltage-gated potassium channels we've known for a long time are in the juxtaparanodal region, and the internode has myelin protein 0, PMP22, myelin basic protein, which helps form the compacted myelin. So once again, periaxin, which mutations of recessive mutation cause CMT4F, has to do with internodal length, and the myelin thickness has to do with neuregulin. Axonal diameter, on the other hand, has to do with aspects of neurofilaments. And I'll show this now, but I'll show there are different adhesion molecules, and one of them is there's tight junctions and adherence junctions between the myelin paranodal loops, and there are these other adhesion molecules that affect the paranodal loops to the axonal lemma. And this is a very important issue that we'll get to towards the end of the talk. So I'm going to go back to some basics, back to 1939, which showed that the action potential that the conduction velocity is dependent on the axonal diameter. And I bring this up in part, we're going to talk a little bit more about this tonight, about how we determine whether something has demyelinating conduction slowing or not. But the key is to know that different diameters, the smaller diameter fibers conduct slower, and the larger diameter fibers conduct faster. The other part of conduction that we don't think about as much, but we know about for a long time, is this issue about myelin thickness. And what we call the G ratio is a way of describing the ratio of how much myelin thickness there is per total diameter of the nerve fiber or the axon. So the G ratio in peripheral nerve is about 0.6 to 0.8. So roughly the axon should be about 2/3 the total diameter of the nerve fiber. And the myelin would therefore be about 1/3 of it. And when you change that G ratio, either make the myelin too thick for the width of the axon, or you do the opposite and make the myelin too thin for the diameter of the axon, you perturb conduction velocity very significantly. So there are things that cause thin myelin, and we think about it always in terms of remyelination. So when something is demyelinated and you get conduction block, when you remyelinate, you usually get thinly myelinated nerves, at least for a while. But you can also do it by having axonal swelling. So giant axonal neuropathies then have a large axon, which with a normal amount of myelin, and that will change that G ratio and cause conduction slowing. So this axonal neuropathy causes conduction slowing that would make you think of demyelination. On the other hand, we've known for many, many years, there were studies back in the 70s of axonal shrinkage in diabetic neuropathy. And in fact, Peter Dick's work on CMT actually noticed axonal shrinkage, and he thought CMT1 was actually an axonal neuropathy based on that. And there are some, and it turned out not to be true, but axonal shrinkage is a significant factor in a number of neuropathies. Neurofilament disorders also can cause axonal shrinkage, and there's some question about whether anti-MAG neuropathies, the distal accentuated slowing in that disorder is from actually the axon shrinking rather than demyelination at those sites. So you're all aware of this. Unmyelinated nerve fibers conduct very slowly, 1 to 2 meters per second, and myelinated fibers conduct much faster depending on the axonal diameter and the G ratio. And will this one work? So this slide, and I'll show it a few times, has a conglomeration of a whole bunch of stuff. So this is a relatively normal segment. This is a paranodal change. And this is obviously a demyelinated or unmyelinated segment. And this is actually a little artificially done because demyelinated nerves do not have continuous conduction velocity, but I use it to show what an unmyelinated nerve fiber would do in terms of conduction. And you can see how slow it takes to traverse this segment because of the lack of myelin. And then you get a relatively normal potential, and in this instance, you got a relatively normal action potential again. So this shows a number of different changes. I'll do it one more time and then.
What is the actual elapsed time of that video?
I don't know. Some of these are slowed down. The first one I think was faster. So some of the videos are slowed down and some of them are speeded up. So I don't really know that.
Can we use like tens or hundreds of microseconds?
I wish I could tell you. I don't know the answer. He sent me the videos, not the knowledge. So again, what was surprising here, one would have thought that you would have gotten conduction blocked in the segment, and in this instance you didn't. Although this action potential, these were all distorted to some respects. So these are talking about single nerve fibers. But when we do nerve conduction studies, we're looking at a population of fibers. And we try to interpret what a single nerve fiber would do based on this population of fibers. So the way to think about this, and people have a problem with this, and I don't quite get it to some extent. If you figure out that the smallest motor nerve fiber is roughly in this 5 to 6 microns, it means that that conduction velocity is going to be slower than the smallest nerve fiber in the arm. That's why the normal conduction velocity in the arm is 50 and the leg is 40. It's because the nerve fibers are smaller down in the foreleg than they are in the arm because of length. But you can have the small, if you cut every motor nerve fiber but the smallest in the leg, you might still get a velocity of 25 meters per second in that remaining fiber. In the arm, you really shouldn't get anything under 30 meters per second. So by definition, if you get a conduction velocity under 30 in the arm, it means there's something wrong with the myelin. And in the leg, it means there's something, it needs to be under 25 meters per second. I cannot tell you how many cases of CIDP I've seen people diagnosed because the velocity was 30 when the amplitude was 0.1 millivolts. It just is not, it's not a sign of demyelination. Now the question that I could raise is, if we just had nodal and paranodal disorders, would you get down to these velocities? And it's possible, but we don't know that answer.
And so, Richard, is that one of the explanations for why most neuropathies start clinically in the feet and the lower leg?
Well, I mean,
or is it more complicated than that?
Length-dependent neuropathy is probably related to the length of the axon from their either DRG or the motor neuron, and the length dependency is more likely to be an axonal loss rather than a demyelinating. I mean, the only distal accentuated slowing that I'm aware of is really an anti-mag neuropathy, which is not necessarily length dependent so much, although there's an aspect of it that is. But it's really the axonal loss. So one is presumed that whatever multiple potential causes of an axonal loss, distal axonal loss can occur, but it's the length of the nerve that does it. Whether it has to do with neurofilaments, whether it has to do with mitochondrial dysfunction, whether it has to do with changes at the node of Ranvier. For instance, we'll hopefully get to this a little bit at the end, but a multifocal motor neuropathy, even when you treat it, the IVIG seems to help preserve function for a while, but they get a length-dependent loss of nerve fibers over years with that, presumably because there's so much energy change at the node of Ranvier in these patients that they end up getting axonal loss, which is length dependent. The other disorder that does something very similar is HNPP. So we know that HNPP, where there's conduction changes at sites of compression, but there are changes with maculae in all the nerve fibers. Those patients, if you follow them long enough, and Garth Nicholson and Jun Lee showed this 10, 15 years ago, they get a length-dependent neuropathy. And the thought on this is that these chronic changes at the node and paranode cause major energy issues, constriction of neurofilaments and others that end up causing a length-dependent distal axonopathy. I don't know if that's clear, but that's kind of the way I think about it. So in myelinated fibers, potassium channels actually have very little to play in the repolarization of myelinated nerve fibers, but paranodal retraction exposes these potassium channels and then causes a redistribution of sodium channels and marked changes in conduction. So that's one of the reasons why paranodal retraction causes both conduction block and conduction slowing, and it's quite dramatic. So this is what I was saying before. If one cuts all the motor nerve fibers in the arm, then you really can still have a velocity of around 30, but anything lower than that shouldn't, and 25 meters per second in the distal leg. So you might ask, well, Dr. Lewis, why are all these criteria for demyelination saying 70% of the lower limit are normal? So 70% of 50 is 35, 70% of 40 is 28, so we're pretty close. And the answer is, while this is absolutely true, the probability of a demyelinating neuropathy between 30 and 35 is very high, even with relatively low amplitudes. In the leg, it would be between 25 and 30. It's still possible, but less likely. So in CMT, we describe the CMT1, the myelinated, the dysmyelinating form of CMT, as being less than 38 meters per second, and CMT2 as being greater than 38 meters per second. And that fits, again, between that 30 and 38. Most of them are going to be demyelinated, but not necessarily all of them, which is why we have this whole intermediate group that mixes it up. So I wanted to go over, again, some basics about the electric diagnostic findings that suggest demyelination. These are the ones that people talk about. But the ones in yellow are really the ones that are most specific, because there's no axonal disorder that can cause segmental slowing. If you cut an axon, you just don't get a response distal to where you cut it. But you wouldn't get some portion of slowing and some portion that's not. The only thing that does that is a demyelinated segment, and temporal dispersion is essentially segmental slowing of the intermediate fibers, and the distal accentuated slowing is also a segment that's slow compared to others. Now the distal accentuated slowing part, again, because it's distal, conceivably it could be from axonal atrophy. So conduction block, you all kind of know what it is. You get a response distally that's relatively normal, and then at some point you lose that response, and it has nothing to do with conduction velocity, although frequently it gets slow, but it's the amplitude that drops. And that amplitude drop is suggesting that a certain percentage of the nerve fibers that you stimulated at the wrist are not conducting through a lesion more proximally. Temporal dispersion we've talked about, and I think I've mentioned that, so I'm going to move on. So again, what do we know about this conduction velocity related to some of the things we talked about earlier on? Myelin thickness, we know if you take neuregulin plus minus mice, which reduces the myelin thickness by 20%, changing your G ratio, the velocity reduces about 25%. Very significant amount for reducing that percentage, 20% reduction. And a periaxum mutant mouse that has shortened inner nodes has a 50% reduction in nerve conduction. So that internodal length is very important, which is one of the reasons why patients with Guillain-Barré syndrome, if you study them a year or two later, they may not have normal velocities because their remyelinated segments may be shorter internodes. And some of the actually skin biopsy work that Jun Lee and Mario Saporta did showed that there's a lot of shortened internodes in PMP22 duplication or CMT1A, and as you know, they have a very significant velocity change. And axonal diameter can also change it. Neurofilament disorders can have very slow conduction velocities. So I mentioned this septate junction between paranodal and loops and the axillemma. And the changes here do slow conduction, although not that dramatically. But the exciting thing for those of us interested in CIDP is that there have now been described some antibodies against those components. So neurofacin 155 and contactin antibodies have been shown to cause a certain type of CIDP. It's usually pretty severe. The neurofacin ones has a fair bit of tremor. They are motor, more than sensory. They do not respond to IVIG, and they've been shown to be IgG4 antibodies, which are not complement mediated. What other neuromuscular disease is IgG4? Anyone? Residents? Fellows? Important neuromuscular disorder. Myasthenia. Okay? So myasthenia, which can be a very devastating disease, was terrible to treat. And I had a patient who was being intubated twice a year for 8 years with a MuSK antibody and had the classic syndrome of neck extensor weakness, shoulder weakness, bulbar dysfunction, and did not respond to steroids or IVIG. And we were trying to control with plasma exchange with partial success. She went at least 6 years after her rituximab without any further. She had some residual permanent damage, but had no further exacerbations. Myasthenia is rituximab and B-cell depletion is like a miracle drug for these patients. It's essentially curative in many instances. There are some other IgG4 antibody disorders, but finding these are important because the treatments are different than you have for IgG1 and 3, which is the receptor antibody disease in myasthenia. And so B-cell depletion is correct disorder. But the detection of these antibodies in CIDP are basically the first antibodies that we have found for this. So we think about GBS, we have AMAN, and we know that they're anti-ganglioside antibodies to GM1 and GD1A. But AIDP, which in the United States is more common, we still don't know what it is. MMN, we have association with GM1 antibodies, but like AIDP, CIDP, its chronic cousin, we still didn't have any antibodies. These are the first that have been described in CIDP, and they have found some of these IgG antibodies. These are IgM. They have found some IgG antibodies in some cases of Guillain-Barré syndrome, or AIDP. So another mirror. So I don't know how much time. Yes?
I had thought there were some CIDP cases associated with P0 in the past. Is that true?
There have been a number of different antibodies that have been discussed with this, but they've never held. They've never been shown to be persistent. No one's been able to follow up and find a percentage of patients with it. These seem to be fairly clearly defined. But you're right. People have looked, and P0 was one of the ones that they talked about a number of years ago and it didn't show up.
But do we have any sense of what percentage of CIDP patients have?
No, not yet. I'm sure people are looking at it. So I think there's a number of people sending CIDP samples to Isabel Illa in Barcelona to look into this, but we don't have the answers yet. If you go to Glasgow, we may find out. So, Tom Bird and I remember this well. These cases came out back in the early 2000s, I think, where adult forms of myelin protein 0 mutations, CMT1B, were said to have an axonal phenotype. And if you looked at the conduction velocities, there may have been some conduction slowing, and you could have argued, was there a myelin component? But clearly there was a lot of axonal loss and very little conduction slowing. But myelin protein 0 is a myelin protein. There's none of it in the axon. So why should a myelin disorder cause an axonal phenotype? There was a similar discussion and argument about connexin 32, or gap junction beta 1. And the recognition that adult onset CMT1B has a lot of axonal loss with very little conduction slowing really triggered a lot of the research that's been done to try to understand this axonal myelin interaction. So we've talked about giant axonal neuropathies causing axonal disorders with demyelinating physiology. The other ones that do it are the hexacarbons. Hexacarbon neuropathy causes giant axonal swellings. They sometimes stretch the myelin so they can actually look like they actually demyelinate it, but the G ratio changes anyway, so there's some slowing with that. And they get very significant demyelinating looking slowing. The axonal shrinkage story is a little bit less clear, and how much slowing one gets with axonal shrinkage is not clear, but if we believe the mouse data on these neurofilament deficiency, it can slow it quite a bit. So again, changing that G ratio makes a huge difference. So we need to think about these things and not say that someone who has conduction velocity slowing in quote-unquote the demyelinating range is demyelinating. It may not be, so we should always keep an open mind. Here's some axonal swelling. Some disorders, like in these hexacarbons, they can get some areas of swelling and some axonal shrinkage right near it. So what are some of the nodal and paranodal disorders? AMAN is obviously one. MMN we'll talk about again. We've already talked about CIDP, and I want to get into HMPP a little bit. So you all know the story about Campylobacter jejuni and AMAN, and I'm not going to go into that very much. These are IgG1 and IgG3 complement-mediated disorders. We know that the complement and the macrophages occur at the node of Ranvier and spare the paranodal loop, although there can be secondary paranodal changes, and they can get conduction block. They get a lot of axonal loss, but they can get conduction block purely from this change in the node of Ranvier. We've always known that conduction block can come from other things. That's what Novocaine does, or lidocaine. When you eat your pufferfish sushi and get some tetrodotoxin or saxitoxin, you get a sodium channel block. So, and that will cause conduction block, and it's nothing to do with myelin. But demyelinating neuropathies can certainly do it, and some of the acute changes in MS presumably are related to conduction blocks that are central. We've talked about this. There are drugs that can affect the sodium channels. Dr. Weiss is like intimately in love with one of the drugs. He's passionate about it.
It's a flirtation only.
Your wife feels better about it. I'm glad. So, MMN for a long time was felt to be a demyelinating neuropathy, but there's been a series of studies that have shown both pathologically and physiologically that MMN is probably the chronic restricted form of AMAN. And so it really is a nodal disorder. And axonal excitability is suggested physiologically. Pathologic studies done in Mayo Clinic showed no inflammation, no demyelination, but Wallerian degeneration in a biopsy of fascicles at sites of conduction block. The last few minutes, I'm going to talk a little bit about HMPP, and all this work has been done by Jun Lee, and it's really a series of very interesting work that not only explains what happens in HMPP, but also helps us understand what PMP22 does. So as you know, hereditary neuropathy with liability to pressure palsies is an inherited disorder. It's due to a deletion of PMP22. So CMT1A has 3 copies of PMP22. HMPP has 1 copy. The hallmark of the disease is temaculi, these focal myelin redundant swellings. And there are physiologic changes, are conduction slowing in the, and conduction block. So Jun and I, a number of years ago, looked at a whole bunch of HMPP, and there's some very characteristic changes that you see in HMPP in patients who are just otherwise feeling normal. They don't have any acute conduction blocks at the time, but chronically they all have conduction slowing at the elbow. They all have conduction slowing at the perineal nerve at the fibula head, and they have prolonged perineal and median distal latencies, but the tibial latency is always normal. So it's not distal, it has to do with sites of compression. And you can see these patients when they are referred for carpal tunnel syndrome. You can see them when they're referred for radiculopathy, and they can be confusing because you see all this conduction change outside of the area that you think, and you say, oh, they have CIDP, or they have Lewis-Sumner syndrome, which I made the misdiagnosis of once. And the answer is all the conduction slowing in HMPP is at the sites of compression. And as I said before, this distal axonopathy occurs over years later. So again, all this is from Jun's paper, but there are a number of different junctions that relate to the myelin and the axon. And we talked about the septate junctions, which, well, this line seemed to move when we shifted to the PC. But this line is supposed to go to these septate junctions that attach the paranodal loop to the axillemma, and the tight junctions are between the paranodal loops. So it kind of keeps them tight. And we've always thought, without a lot of data, that PMP22 interacted with myelin protein 0 to form tight, compacted myelin. So when you lose these tight and adherence junctions, it has a profound effect on the safety factor of transmission. So in the HMPP knockout mouse, the plus-minus mouse, these tight junctions were shown to be dislocated. And it basically made the myelin much more permeable to shunting of current. So you would therefore have some chronic changes at those sites, and then any kind of perturbation, such as compression, can cause failure of conduction due to the safety factor loss from this tight junction. So the temaculi and HMPP, a lot of the reason why they are excessively liable to compression has to do with this loss of these tight junctions. And on that note, I would just summarize, my interest in this is that I've had this thinking about conduction slowing one way, that it meant demyelination. And we're now learning a lot about the submolecular biology of the myelin and the nerve, that I think we need to start rethinking this a little bit. That there's more nodal disorders causing these problems than we thought, more paranodal disorders doing it, both from an inherited, toxic, and inflammatory disorder. So on that note, I thank you very much. And I think I was supposed to do something here, but I don't remember what. Yes?
Rich, that's a great talk. I had a question for you about anti-GM1 antibodies in multifocal motor neuropathy and physiologic conduction block. So for a long time, we used to think that most of these patients had anti-GM1 antibodies, and that there's some evidence that these antibodies are causing physiologic conduction block at the nodes of Ranvier. And now we find that now it's clear that most of these patients don't have, or at least maybe up to 50% have these antibodies. So do we still think that do you still think that that's likely that we're seeing physiologic conduction block? And is that true for all MMN patients or just some of the patients that have these antibodies?
Well, I think they have conduction block.
Yeah.
And I think the conduction block is occurring because of changes at the node and paranodal region. Whether the GM1 antibody is the cause of it is another story. Now, if you remember, Dr. Pestronk had published that 80% of his patients had antibodies to the co-GM1 sort of, and when that was attempted to be reproduced, they found 35 to 50%. Recently, Hugh Willison has been complexing the GM1 with other gangliosides, and what he came up with GM1 and galactocerebroside, he then found about 85 or more % of his patients with MMN had an antibody to that complex, but not to GM1 alone. So the GM1 story may be related to these complexes, which is a little similar to what Angela Vincent found when she complexed receptor antibody and found the percentage of patients who were receptor antibody negative to the single receptor were positive to a complex having to do with the targeting of getting antibody to both sites. So I think GM1 story is still out there. I personally think it's related. I don't know if that's the whole mechanism, but I think it's related.
But the argument was that for why these antibodies might be having this physiologic effect is that GM1 is enriched in the node of Ranvier, and so it's galactocerebroside also enriched in the node of Ranvier?
That I don't know. And it may be that certain people have it. I do not know the answer to that. Yeah. Yes, Tom.
So is it known how myelin P0 interacts with the axon? What the mechanism is?
Not that I know
I
of.
haven't seen anything.
No, not that I know of.
It must be in some important way.
Or the other way of looking at it is mutating. So if you know, there's two forms of CMT1B. One is the childhood form, and certain mutations cause a very severe demyelinating Dejerine-Sotas type phenotype with conduction velocities of 3, 5, 7 meters per second. But adults who onset CMT get this axonal phenotype. So the question
They have different mutations.
right, and the mutations presumably have different effects, but clearly the mutations in the adult form affect myelin's effect on the axon, where the childhood ones clearly affect conduction as well as the axon. They lose a lot of axons, it's a severe form. What myelin protein 0 does to the axon when it's healthy, I don't know. It clearly does something when you mutate it to cause axonal loss. And what that is, I don't think anyone who's working at it, I mean, Larry Ravis should have figured this out for us already, right? So I don't know. Yes?
If such a small segment of demyelination can cause a block that may be complete, how do the small unmyelinated fibers carry their signal?
They don't have, how does unmyelinated fibers have continuous conduction?
Right, and not just, blocking.
Well, for the repolarization in unmyelinated fibers, normally you have potassium channels active, and when you lose some of the paranodal retraction, you then expose potassium channels in myelinated nerves that normally are inactive, and you redistribute sodium channels. So it's the pathology of the paranodal retraction that causes the change. In unmyelinated fibers, you have a normal distribution for what unmyelinated fibers are supposed to have, and potassium channels do what they're supposed to do, which is to help repolarize the nerve. That's the way I understand it. Yes? Ladies first.
Okay. My question is, ratio you mentioned really important for conduction. And I wonder the significance of the G ratio is from observation, or it actually is some conceptual understanding toward that. The reason I'm asking is I'm thinking about the giant axon and the myelin. If the myelin thickness change, the contact surface area with axon probably doesn't change that much.
Mm-hmm.
And seeing the slide cartoon of interaction between the axon membrane and the myelin membrane, that's my question, really.
So, if I understand the question correctly, that is, what is it about the G ratio or myelin thickness that really is affecting the conduction velocity? And I'm not sure I'm the person who can answer that question completely, but there are biophysical constructs that explain that the normal G ratio and the normal internodal length per axon is the physiologic, biophysically, is predictive of being the most beneficial for conduction. And what that it has partly to do with, and I don't understand it exactly, but mobility aspects within the axolemma and the lipid bilayer, but I can't speak. But it has been described as being, it makes sense to biophysicists that this ratio works. It's the best I can tell you on that one. Yeah. Yes.
Related question to Dr. Ma there when you mentioned the potassium channel. So these anti-Casper antibodies, I can't help thinking of anti-voltage gated potassium channel, the Casper versus the IL, LH2 or whatever it is. But is the Casper the same as what we're talking about with antibodies and voltage gated potassium channels? Is that Casper a potassium channel?
Not that I know of.
Okay.
But I mean, but whether the Casper has something that affects the potassium channels, I don't know. And the voltage-gated potassium channels, I don't think is in the slow potassium channels. I think it's against the fast potassium channels, but I'm not sure about that.
I think they're fast potassium.
Yeah. Which, yes.
They're different cell types, but do the same molecular players, neuropathy and periaxin, determine myelin thickness and internodal length in the CNS?
I don't know. There's any CNS biologists here? I don't know.
Okay.
They're both in. Is periaxin in the CNS? I don't know the answer to that. Tom, do you know? Wish I had answers. I presented this because I'm intrigued, not because I know anything. Well, if there's no other questions, I don't think there's anything else. Well, thank you very much. I appreciate it.